Hello, my name is Jody Barth. I'm a physical therapist from the Center for Facial Recovery, and I'd like to take a few minutes to talk to you about facial anatomy. We at the Center for Facial Recovery feel knowledge is power. By understanding what is happening to your facial nerve and surrounding tissue, we feel it will help in your recovery and understanding the process. The facial nerve is considered a cranial nerve, which means that it comes from the brain stem and not the brain. The facial nerve is cranial nerve number 7, which is located in this part of the picture. The facial nerve is responsible for facial muscle activation, as well as salivary gland activation, as well as sensation on 2/3 of your tongue, the roof of your mouth, the blink reflex, and your tear ducts. Right next to the facial nerve, there is another nerve called the vestibular cochlear nerve. That vestibular cochlear nerve, which is cranial nerve number 8, is responsible for balance and hearing. And many of you have suffered through vertigo, symptoms of vertigo, dizziness, hypersensitivity to sound, or tinnitus. And that comes from inflammation of this vestibular cochlear nerve. The third nerve, cranial nerve, that gets involved is the trigeminal nerve, which is cranial nerve number 5. And trigeminal nerve is responsible for the sensation of the face as well as your chewing muscles. This is a picture of the facial nerve, and it is showing where it is leaving the brainstem in this area here. And this is a long bony canal that the facial nerve goes through. It starts at this geniculate, it goes to this geniculate ganglion, and then comes all the way down and comes out behind your ear before it goes into the 5 branches. The 5 branches are the temporal branch, zygomatic branch, buccal branch, mandibular branch, and cervical branch. This long tube is very small, and the facial nerve has a tight fit when it's normal. When the facial nerve is inflamed from herpes zoster virus, or in Bell's palsy, herpes simplex virus, or in Lyme from the Lyme bacteria, there is swelling of that facial nerve in this canal. That swelling causes compression of the facial nerve, and it does not allow then the facial nerve to send its signal or bring that what we call the neurotransmitter, which is the energy that powers the muscles. Until that swelling goes down, there is no activity to the muscles. Once the swelling is reduced, then it takes 1 day for the nerve to regenerate 1 millimeter. And that is why it's so important to get on the proper medication initially, including steroids, antivirals, and even calcium channel blockers. When we see recovery occurring after the facial nerve swelling has reduced, typically it goes down one of the shorter branches, and that is in the corner of the mouth. So many of you will see recovery first in the corner of your mouth, and there is recovery that comes to the muscle in the neck area. Typically, when you have severe inflammation, the areas that come back the last is the branch that comes down to this lower lip area, to the forehead, and around the eye. And a lot of that has to do with just the distance. If you think about that the nerve takes 1 day to regenerate 1 millimeter, this is a very long distance. And again, this regeneration does not occur until after the inflammation is reduced so that the nerve is not swollen in that area. In this picture, you can notice that each main branch has smaller fingers, and each smaller finger goes to a particular muscle or a particular area of the muscle. So that is why when we're doing neuromuscular re-education, we're doing it slow and controlled, so that we're just working on the area of the nerve that we want to start encouraging the muscle to activate. This is also why we don't recommend electrical stimulation. Electrical stimulation will trigger all of these nerves firing at the same time and could lead to abnormal nerve regeneration, which could lead to synkinesis. When we talk about abnormal nerve regeneration, what occurs is the branches, for example, from the mandibular or the buccal branch area will come and have a abnormal branch thrown up towards the eye area, and that makes the connection between the eye and the mouth. The brain knows that it needs to close the eye. So the muscles of the eye, more than anything else, are calling very strongly for the neurotransmitter that the nerve is to deliver. And when the nerve that is supposed to bring the neurotransmitter to the eye is not functioning yet, then other nerves will try to help. And that's why typically you'll see this synkinetic connection between the eye and the mouth. The other areas that you see as a synkinetic connection is from this muscle down here, which is called the platysma. And that platysma comes all the way up, and it helps with nerve regeneration up the pathway. This is a picture of the trigeminal nerve. Again, the trigeminal nerve is cranial nerve number 5. As you can see in this picture, that the trigeminal nerve brings sensation up around the forehead, down around the nose, and around the eye area. And that's called the first branch, or V1 of the trigeminal nerve. The second one is in the midface, and the third one is in the lower face. When you do have inflammation to the trigeminal nerve, it could be displayed as pain in these areas, hypersensitivity to touch, or less sensation. So not necessarily numbness, but when you touch it, it'll feel less than it feels on the other side. If you have any of those symptoms, then that's an indication that the trigeminal nerve was also irritated, and things such as massage will also help with the trigeminal nerve regeneration. This is just a picture so you understand again of where what we call V1, V2, and V3, where that sensation is, all from the trigeminal nerve. You do not get the sensation of the face from the facial nerve. This is a picture of the vestibular cochlear nerve that I referred to before, number 8. And the vestibular cochlear nerve is for balance and hearing. And so many of you might display signs and symptoms of vertigo, or don't even realize that your vestibular system might be impacted. One of the ways that you can check your vestibular system is stand on one leg, have somebody spotting you, or be close to, say, your kitchen counter. Stand on the one leg and see if you can stand there for about 30 seconds, and then do the same on the other leg. Then the next step would be to try to close your eyes and see if you can stand on one leg for 10 seconds without losing your balance. Again, you should be spotted when you are doing this. If there is difficulty when you're closing your eyes, that's an indication that the vestibular nerve has also been inflamed, or the vestibular cochlear nerve. And in that case, you would benefit from vestibular therapy. The other part of this nerve is the cochlear nerve, which is your hearing. So when you have hypersensitivity to sound, then that means that cochlear nerve has also been inflamed. We do recommend every patient who has facial palsy should get their hearing checked just to see whether or not the cochlear nerve was impacted. And if there is severe inflammation of that cochlear nerve, other treatments can be done, such as steroid injection to that area. The stapedius muscle is the smallest muscle in the body, and it is innervated by the facial nerve. So what happens many a times that stapedius muscle initially is not getting the innervation it needs, and it works with a very small bone that helps with the hearing. And when you are suffering from things such as tinnitus or ringing in the ears, that is also an indication that the stapedius muscle is not doing the job it needs to do. The other interesting thing to note is that many of you might notice that when you smile or pucker or do some motion of the oral expression, that you hear tinnitus or noise inside your ear. And we think that could be a syncretic connection between the oral region and the stapedius muscle. This is a picture of all of the facial muscles. And what's so important about this is to see how they are blended together. Yes, they are individual muscles, but when we're talking about where they start and where they end, they are very interconnected, which makes it hard when you are isolating out muscles when they are weak and trying not to use other muscles to move. So for example, if you are trying to show your upper teeth and use your levator muscle that's here, a lot of times you'll use the muscle and bring up the cheek area. You can see in this picture as well, this is a picture of what's called the galea aponeurosis, which is fascia. And this fascia is throughout the body, but it is interconnecting of different muscle planes in this area. One of the muscles I want you to be very aware of, I'm sure you have heard about the surgery that's being done that's removing this depressor anguli muscle. The depressor anguli muscle is your grimace muscle. And a lot of times when you have facial palsy, that depressor anguli muscle returns and is very tight and strong, and that shuts down what we call this depressor labii muscle. This depressor labii muscle is responsible for pulling the lower lip straight down. You need that lower lip straight down to be a stabilization vector to allow the corner of your mouth to give you a better smile. So when they are doing the DAO resection, they're going in and cutting this muscle to give this depressor labii muscle a better chance of activating and allowing the corner of your mouth to pull up better. I thank you for your time. And if there are any questions that you have or further information that you need, please feel free to contact us at info@facialrecovery.com.